I have no idea if you guys will find this interesting at all, but I figured I might shoot a few videos before I go visit my inpatients. And you guys will obviously see this when I post it to YouTube. So that's what I'm about to do, is film a video. This video is going to be a little bit different. Now that I'm in clinicals and everything, I've been trying to work through my own kinks, figure out my style, and how I talk to patients, how I care for patients in the OR. So I'm now finally a little bit more comfortable and ready to give you guys a little bit of how I go through clinical every day. So if you are interested, maybe you're going to be starting clinical, just curious about how it works, just keep watching. The first thing that happens when you are about to give a patient anesthesia, the first thing that they remember or may not remember is your interview with them, your pre-op interview. So that's actually the reason why I'm wearing this stuff. Like, I never wear, who sits around like this? I don't sit around with my stethoscope on, but I'm about to go back into the hospital because I have an inpatient. So my school requires us to go to the hospital if we have inpatients there. So if someone was staying there overnight, has been there for a long hospital stay, we have to go in and do a pre-op on them before our clinical day with them. Otherwise, I would not be wearing, like, who sits around in a lab coat? Not me. Speaking of lab coat though, this is the new Figs one. Okay, so back to this video. In terms of anesthesia, it's a little bit different if you were to complete a full head to toe interview with your patient, if you were, say, an NP or a doctor seeing a patient for a physical. All of our questions are geared towards figuring out if any medications or any of their past medical history will impact our anesthesia care plan for them immediately for that day and that surgery. So yeah, you might be interested in that ulcer that they have on their toe, but not really. So what's really funny is when you're talking to patients and they like to give you every little bit of detail, you kind of have to redirect them. So this video, I'm going to try to give you a clear, concise, a quick head to toe, and then tell you how and why your head to toe might be a little bit longer depending on your patient and their issues. So just as you would in a hospital, you a lot of times can have your computer by you and pulling up your patient's chart. I'm not going to be specifically talking about a patient because obviously HIPAA, but I will draw some ideas, and this will just be really, really random. So first thing, when you walk into your patient's room or their pre-op bay, you introduce yourself, shake their hand, introduce yourself to the rest of their family, ask who everyone is. I think that's just basic human politeness. And then you introduce yourself. What I like to say is, hi, my name is Aisha. I am part of your anesthesia care team today. I'm going to be working with the anesthesiologist and the CRNA, blah, 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 and I'll say their names. Sometimes, depending on which facility I'm at and if I'm required to say that I'm an SRNA, I will. A lot of times I don't really mention it unless I'm asked. If someone has a question, okay, so what is an SRNA? I'll say, well, I was a registered nurse and now I'm back in graduate school learning to give anesthesia so that I can become a CRNA. A lot of times I'll say, hi, I am a registered nurse going back to grad school at Duke, and I am one of the 3 people that are going to be working with you in the OR. So once you let them know that you're not going to be alone, there's going to be more people helping you, a lot of people tend to relax a little bit. After introducing myself, I say, okay, so I know you've been asked these questions before, but it just helps us all stay on the same page because I know these people are tired, hungry. So I just kind of try to make it as least painful as possible. I literally do a head to toe that helps me stay in order. We had a health assessment class specifically for anesthesia, so that was pretty helpful. A lot of times schools make you go through a whole health assessment course that like NPs take. It's really not necessary because a lot of that stuff we don't need. Like, I don't need to be doing a pelvic exam on you. No. Or a reflux patient, or they have asthma. A lot of times they say they have taken some type of medication that day. If they've had any issues with anesthesia before, last time they had anything to eat or drink, and if they are in any pain. Last time you had anything to eat or drink. And they'll tell you. A lot of times they'll say, I didn't have anything since last night. But then they forget about the preemptive analgesia medications that sometimes we give. So I said, did you have anything to eat or drink this morning? And they'll say, oh yeah, I had a sip with meds. And I said, okay, so what medications did you take? A lot of hospitals follow an ERAS protocol where they're giving Tylenol, gabapentin, Lyrica, things like that. And so I ask them about those. And then I say, did you take any of your regular scheduled medications this morning? You know, I'm looking in the chart to see if it's amlodipine or verapamil, metoprolol, anything like that. Beta blockers are a very, very, very important thing to see if they have taken or not. So I check that off the list. Then I move to anesthesia. Have you ever had any issues with anesthesia before? And then so a lot of times they don't know what you want them to answer. So you can kind of give them some prompts. So I'll say like nausea and vomitings. Have you ever had a fever? Anybody in your family have a history of trouble with anesthesia, fever, or high temps? That's cluing me into whether or not the patient is at a risk for malignant hyperthermia. So you want to ask about the familial history as well as the patient themselves. If they say, yes, I woke up very, 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 very nauseous, or I was told that I vomited a lot, that clues me in to say, okay, maybe I want to give this person some more antiemetics during the case, and maybe preemptively with the scopolamine patch, Benadryl, Reglan, Phenergan, any one of the Zofran, obviously we give a lot of that. So that kind of gears your anesthetic plan some more. So for the heart, now I'm going to be acting like I have not seen this patient's history, because you never know if this patient was in the ER or didn't have a chart in here. You want to be able to hit your major systems. So head, do you have a history of seizures or strokes in your past? They say yes. Are there any residual effects of that? Left-sided weakness, right-sided weakness, numbness or tingling in your hands or feet. Then I move on to heart. Have you ever been told that you have a funny heart rhythm? Do you ever feel chest pain or palpitations or fluttery heart? Do you take blood pressure medications? Do you ever get short of breath? Do you have to sleep sitting in a certain position? So that all can tell me, do they have heart failure? Any history of palpitations, possibly undiagnosed AFib. Obviously, we have an EKG that we're going to look at, but this is what is coming from the patient. So then I'll move on to respiratory, shortness of breath, walking up a flight of stairs. Do you have asthma? Do you smoke? Do you use an inhaler? When's the last time you had to use your inhaler? Do you snore? Has someone told you that you stop breathing when you sleep? Then I'll move on to the stomach area. Do you have reflux? Are you nauseous? Do you have nausea and vomiting, heartburn? Do you take anything for this? Does it work? Is it over the counter? Is it prescribed? Then I'll move on to liver or kidney. Do you have any liver or kidney issues? Difficulty urinating issues, have you ever been told that you have any liver issues? Have your liver labs been off? Those are really, really important for the elimination and metabolizing of drugs. So when someone says, yeah, I have a liver issue or a kidney issue, that clues me in to say, okay, so maybe I need to be a little bit careful about the certain drugs that I choose, how much I give. They may not be eliminated as quickly as someone who has normal function. So I did the stomach area. If I know this patient has a lot of other comorbidities, I might ask them, do you have a thyroid issue? Do you have a clotting issue? Musculoskeletal issue? Do you have any deficits anywhere? Because that's very important to ask, because you never know. We are in charge of positioning our patient. So if you have a patient has a deficit, you need to know that up front, because they could wake up and say, oh my gosh, I can't move my arm now. And that's on anesthesia, because we are the last people to check positioning. We are in charge of that patient. That's a quick basic assessment. Now, in an emergency, my assessment changes. I haven't had that many emergency cases. I think I've done about 6 or 7 really, really emergent cases where my patient could barely talk to me. And so the first thing that I do is I get really close to them, not too close that they're scared, but I introduce myself in a very calm voice, and I tell them who I am, that I'll be taking care of them. I ask them to shake their head yes or no if they can. I'll say, I'm Aisha. I'm the SRNA that'll be taking care of you today. Can you tell me if you have ever had any issues with anesthesia? Are you allergic to any medications? And those are like the really, really big ones, because if the patient can't speak for themselves, you at least want to be able to know what allergies that they have and if they've ever had like malignant hyperthermia or something like that. I hope you guys like this video, find it helpful. Please leave comments down below if you like these type of videos, and see ya. I just want to give a shout out to Fatima. I was gonna always film an assessment video, but you putting your MP one out, I was like, you know what? let me go ahead and film this now. I'm already going in to see my patient. It'll be kind of cool to see the differences between an anesthesia type of workup and interview and an NP workup. So shout out to you, boo. If you guys don't know who she is, please check her out. She is an NP school. She's hilarious. I follow her on Instagram and obviously on YouTube. We are supposed to be meeting up along with J Vogue. She is a nurse in the Air Force. Absolutely love her. They just crack me up. So they're always posting each other and then posting about their days. So I'm kind of getting like a view of what Air Force is like, and then, you know, I'm kind of getting an NP life. All right, but yeah, peace out, guys.